I have no conflicts. The learning goals for this is to understand childhood asthma, specifically the differences between asthma and reactive airway disease. We'll also explore in more detail the various asthma types and accordingly the therapies and their limitations. Now, asthma is particularly common. We get used to hearing how common it is, but we really forget it. Just to give you an idea, asthma was really quite a rare disease, and in the 1900s was in the rare section disease of textbooks. It has risen precipitously, and particularly over the last 20 to 30 years. Just looking at this in more detail, on a more broader population, it rose from about 2-3% early on in the 1980s and gradually rose into the mid-90s to about 5.5%. There was a little slight change in statistics, but ultimately we can correlate studies from 2000 to 2010, and the rise continues, an overall population average of 8.4%. Now, for children, and particularly in the Boston area, it's about 12.4%, so it's significantly higher here. It's just to have a good idea to understand the number of people affected. Again, just looking at it here broadly, the total number with asthma, 20 million in 2001, and clearly going up here, way up here in 24 million type range. So this gives you an idea, like if you work on 1 in 20 it was in the early 90s, and then we see it then rising to 1 in 14 in 2001, and then now, up to now, 1 in 12. So clearly the frequency is rising. It affects all populations. Certainly the African American population is more affected. You see it running along here. However, these numbers would reflect that it's high in all populations with a disproportionate amount in the African American population. I wouldn't, the things to understand that there are some treatment implications based on different populations, and we'll discuss that a little later. Now, what is asthma is often the million-dollar question. And are we treating asthma or are we treating wheeze? Now, it is important to break out some of the subpopulations here so we understand what's going on. For pediatrics, we have a condition called transient early wheezers, better known as reactive airway disease, or wheezy bronchitis, or baby asthma. This is a condition that occurs early on and resolves. The next one area to look at is allergic asthma. This is the line here going up here, the white line. Now, those are the classical asthma that we understand asthma, high IgE, and that means allergic. And then there's another group that's rising a lot in preeminence in recent times. It's the allergic asthma. Now, most people don't pay much attention to that, but we're seeing more of it, and we'll discuss it more in the context of the obesity outbreak. It's harder to treat, and we'll need to focus a little on this. Now, let's focus on the transient early wheezers. These are the ones I call baby asthma or reactive airway disease. What is that? Now, early studies looked at this, and there's a couple of interesting, and this is from the Tucson study, from Tucson, Arizona. And this study was set up to look at wheezing in childhood. And it broke them into 3 groups. These, of course, the normals here, the transient early wheezers, and this group here, which is we receive is persistent wheezing, which is the allergic asthmatic. Now, from this study, a number of very important parameters that you and I use every day. Now, the first one is transient early wheezers. Now, they don't appear to be allergic. They don't have a higher incidence of eczema. Generally things that don't stand out, no maternal asthma, not really. And then you can see over here, not a really high incidence here. Now, when you look at the persistent wheezers, the classical asthmatic, we see a positive maternal history of asthma. We also see things that jump out, eczema sitting up here, and of course maternal smoking sitting here. Now how does this help us? Now, just what is reactive airway disease again? Well, this is one of the first studies to look at infant PFTs, and I don't want you to be scared away by this, but it's a variation of what adults describe as FEV1. Now, I want you to look on this early study. Look what happens here. No wheezers. This is their flow rates, 1, 2, 3. The transient early wheeze have flow rate in their airways of 76, about 20, 30 to 40% less. Now that means the main problem here is small airways. The airways are smaller. Some people are tall, some people are small. So when they get a cold and get swelling of the airway, they even just get smaller. Hence, they wheeze with every cold during the wintertime. And as they grow, as we see with the lung flows here, over 6 years of life, it goes away. The airways get bigger, hence the child improves. So that is the main issue here. That's the main issue here. Now, there is something else in this slide I would like to focus on for 30 seconds. Now, if you look over here, these were infant PFTs done on persistent wheezers as well, who are ultimately the classical asthmatic. Now, I want you to show you, their flow rates are pretty good as they start compared to norm, maybe a certain percentage less. But I want to point out that they notice that they have a drop in peak flow rates compared to norms at 6 years of age. So even in the classical asthmatic, something is happening in the first 6 years of life that interferes with their airway function. So a real problem, persistent. So to go back again, what is reactive airway disease? It is due to small airway caliber. It is not bronchial hyperresponsive, and the wheezing resolves by 6 years of age. As a classical asthmatic is different. They have a higher risk of atopy, bronchial hyperresponsivity, and significant deterioration in lung function by 6 years of age. This is pretty important to understand because, you know, most people in practice would feel that if they were looking at all wheezers, only 40% are classical asthmatic and 60% are reactive airway disease. And approximately 20% of children have reactive airway disease, so it's very important for pediatricians to know. The other thing to bear in mind about is the treatment of reactive airway disease. Generally, the treatment of reactive airway disease is the giving of inhaled steroids in the winter months. We'll talk about this in detail later on, but certainly this is the most effective way of preventing it and treating regular acute exacerbations with bronchodilators like we classically do. So treatment for winter months with prevention and then albuterol is needed. Now just to break down the second group a little more, we have these classical allergic asthmatics. We all know about them. They have a history of allergic rhinitis, and they have a high IgE, and there's a significantly increased maternal history of asthma. There's a new group which used to be called intrinsic asthma, also known as non-atopic asthma. Now this group is important to know because it's difficult to treat, and we'll discuss it in a minute. So really, two types of asthma. Grossly, the allergic asthmatic, and then the non-allergic asthmatic. Now the allergic asthmatic, we all think of classical groups, but there are multiple subgroups. As you practice more, you'll find out. Now the second group is the non-allergic group. Now they are a group that we know less about, but certainly associated with obesity, and there's a changing natural history of this, and we'll talk about that. Classically, you and I, when we were in medical school, we learned about asthma had eosinophils. Now we're in the airway. Now we're recognizing it's not quite that true. Now, some asthmatics do not have eosinophilia in the airway. They have increased neutrophils or even Pol-C granule. That means less cells. Now, indeed, some people start out as eosinophilic asthmatic and then gradually go over to these two groups. So certainly you could start one and end up the other. Now, why do we need to know about this? Well, eosinophilic asthmatics usually follow the classical pattern and respond well to medications. Neutrophil asthmatics require higher dose of medications, as do the palsy granulocyte. So if you just have classical neutrophilic asthma, you need higher doses. Now, if you started with eosinophilic and graduated to neutrophilic, there's going to be a change in your medication requirements. Now, we all know about what is the difference between the two of them and how they get going. Now, this slide is rich in science, so I don't want you to focus too much on it. The first thing you have to look with somebody with asthma is allergy. We classically think of inhaling an allergen, activating IgE, giving an activated Th2, elevated IL-5, eosinophilic asthma. This is the classical teaching and still holds true. Now, the other asthma is different. So it activates innate immunity. Now, innate immunity really wasn't really well known in the early 90s, and these pathways have only recently been understood. So what happens is, you start off, these pathways can be activated by different things, particulates and pollutions. So ozone can trigger this pathway. Viruses can trigger this pathway, endotoxin, and obesity. So generally this pathway has more ways of entering than the classical allergic pathway. Now, this asthma has changed in front of our eyes. In the last 25 years, we've seen more non-allergic asthma. We're seeing more obesity-related asthma. And we're now recognizing the change from initially being allergic and changes to non-allergic. Now, what is obesity-related asthma? Well, obesity-related asthma is, remember the previous slide I showed you, previous two slides I showed you, was acting through tolls. Most of us cringe when we hear the word tolls, but really it is just a regular pathway of activating inflammation. And it usually activates through Th1 lymphocytes. Now, important facts to remember, 27% of obese children have asthma. Now, it is not mechanical in kids. In kids, in adults, it may be mechanical. The obese cells are thought to be pro-inflammatory and secrete these cytokines which work through tolls. Now, things that we don't know about pediatric obesity-related asthma, but we do know about the adult world, is weight loss does work particularly well in the adult world. And we assume that this is true in pediatrics. We also know that asthma related to obesity is very poorly responsive to medications. And it sets up this incredible catch-22. So what happens is we escalate the medications, and usually what we do is we escalate the inhaled steroids. Hence, they stimulate appetite, and you become more and more obese. So there's a catch-22 situation. So at this moment in time, the focus on the treatment of obesity-related asthma is using non-inhaled steroids. Now, going back to the classical phenotype of allergic asthma, these are familiar to you and I, but most practitioners have recognized for years that there are many different phenotypes, and each one presents with its own challenges. There are the classical allergic asthmatics who present with just virus induction. There are severe intermittent asthmatics, but these ones are particularly difficult to treat because you may have an acute event once every couple of years, and when it is, it's very severe. And should you treat while waiting for that one severe intermittent event? Is there really a crux of the issue? Now, classically, we all know this. Exercise-induced bronchospasm is really common, an important area. And then we know the persistent asthma. These are ones who are symptomatic all the time. They can be persistent, mild, moderate, and severe. And we've classified, and we all understand that group. And then the really severe. And I put the really severe in, breaking it out from the persistent severe, because there's always this group, subgroup, that's just more difficult to treat than anything else. Now, pediatric asthma is different. the teenager is going to ask me why take the medications. And believe it or not, it's actually a very good question. For years, we would say, you are going to damage your lungs. But is this really true? Now, this is the classical picture from Holloway, where it shows a biopsy of the airway, and you see a collagen laid down like this. Okay. However, so the classical teaching was that if your asthma was poorly treated, you'd get increased fibrosis of your airways, and you'd get into more and more trouble with the years. Now, each practicing physician knew that this was probably not true. Probably not true. And then, in 1997, an important study took place. Now, this study was done for totally different reasons, but gave the right answer. Now, what happened was, this was a long-term study being done in Melbourne to replicate what was being done in Arizona, where we talked about early. Now, you don't have to understand the categories, but just let me take you through. What happened was, they took asthmatics and then followed them for years. Now, they put them in each group. They had a control group. Okay? That is wheezy bronchitis, is reactive airway disease. This is the whole group here. And then they had severe asthmatics down here, the pink, and then the milder asthmatics up here. Now, the things you have to learn about this slide is they did a good study, FEV1. Now, what happened was the study was done in the early years, and it was designed mainly to look at intervention, but that part of them did not work out. And really they just followed them, and they were treated in the community. Some treated well and some not. Now, what happened was there was no change in FEV1 over time. So if you started out low, you certainly did not get any worse. So this goes to the question that remodeling is not a significant feature of asthma, and it might not be the reason why you treat. Now, this is one from local studies, so I just want to show you. This one's more dense, and I really don't want you to focus on too much. The higher group up here, see these higher lines? These are normal patients followed over time. And all of these other groups are varying degrees of asthma followed over time. Now, what happens here, you see, this is over many years. You see, over many years. See, there's a normal decline in lung function with time. Okay? It is not increased compared to normal. So normal going down here, so normal going down here. And then these are the males, and these are the females over here. So you see decline, but it's proportional to age, not proportional to severity of disease. So maybe treating asthma to prevent remodeling is not the issue. Now, is there a new remodeling? Now, this is an important question there is. What we mean by new remodeling is that you might start out allergic and have eosinophils in your airway, and then you go on to a type of asthma that has more leukocytes that's less responsive to inhaled steroids. Now, this is possible, but it's not plausible that early giving of inhaled steroids or other therapies will prevent this progression. So, the teenager was right. You should really just take asthma therapy to prevent symptoms and keep you in school and keep you in work. So generally, we're trying to prevent long-term symptoms rather than prevent the complications. Of course, it can decrease mortality, but mortality from asthma is not very high. Now, what is new in a therapy for asthma, and what is the standard therapy? Just to give you, the old guidelines still work, and we'll explore this a little more in a second. However, in younger children, intermittent therapy is being used, but not advised at this stage, but in some parts of the world, it has become standard practice. Now, we're going to talk a little bit more about non-allergic asthma, and in that case, atropine is an old but a new therapy, and we'll talk about long-acting beta agonists. When to treat? Well, nothing has changed. And let me tell you what This is the classical symptom provided by the American Academy of Pediatrics, when to start control of therapy. Now, each one of us would agree with these recommendations. Greater than 3 episodes of wheezing in the last year, that seems reasonable. And a paternal history of asthma or physician diagnosis of eczema. These would seem reasonable, and this is the usual group we treat with controllers. Now, are 2 of the following: physician diagnosed allergic rhinitis or wheezing apart from colds and peripheral eosinophil. That seems reasonable. Courses of steroids, a number of courses of steroids more often than every 6 weeks. I think most of us would have started inhaled steroids long before this. And then symptoms greater than 2 times per week, and nocturnal symptoms greater than 2 times per month. Generally, these are pretty good guidelines. They're pretty good guidelines. And I think the one that most of us use is greater than 3 wheezing episodes in the last year. And then for the more older children, we focus down here. Now, these are the old guidelines, and I just want you to take them through from pediatric focus. And they seem complicated, but they're relatively quite simple. Now let's take a look. We have intermittent asthma and then more persistent asthma here. Now, intermittent asthma, we all use short-acting beta agonists. Now, if they have milder symptoms, most of us have a tendency to start with either low-dose inhaled steroids or montelukast. Most of us in pediatrics start with montelukast. And then if that doesn't work, progress to inhaled steroids. The main reason for doing that is purely compliance. It's purely compliance in kids. Now, if it is the low-dose inhaled steroids and there's still breakthrough symptoms, we progress to medium-dose inhaled steroids. If the medium-dose inhaled steroids does not work and we still have breakthrough, we add something else to the inhaled steroids, and these are now known as combination therapies. The main combination therapy that we use is long-acting beta agonists, and comes under a number of trademarks and very common throughout the world. And then what happens, if that's not sufficient, we progress to high-dose inhaled steroids combined with a long-acting beta agonist or montelukast. And if that doesn't work, we progress to IgE, anti-IgE therapy, namely Xolair. Now, the basic things that you have to remember about treating asthma in pediatrics is you have to use devices, because patients cannot particularly well comply with the inhaler use or nebulizer use. So you have to know the idiosyncrasies of these devices. Now, an old standard rule, which I think is still true, when using nebulizers, even removing a face mask 1 centimeter per face decreases the inspired dose of medication by 50%. 2 centimeters, 80%. These seem wise. Now, you often have a challenge in giving a nebulizer to a 2-year-old who will not stay still. So sometimes even these challenges you have to live with. Now, when using inhaler devices, we use various adapters, and these are spacer devices here, particularly common, comes in a number of different brand names. They're very, very important, and certainly not the most expensive one is effective. This one here is not used very much anymore, but it's very effective. Now, now, looking at a number of strategies, I said to you earlier that maintenance therapy is an important approach. Certainly in Europe and a number of other parts of the world, acute intermittent therapy is being considered. Now, this is a study, an important one to look at. And what they aimed at this was when people become acute with viral illnesses, to aggressively treat. Now, they looked at 238 children, aged 12 to 15 months. So this group is not really classical asthma, probably more reactive airway disease. They had 2 episodes in the previous year, 2 urgent care visits, or 2 oral courses of steroids, or 1 of each. And then primary outcomes were episode-free days. Now, I just want to show you how this worked out. Now, this was surprising. the mean proportion of episode-free days. Now, this was conventional therapy over there, so 74%. Budesonide given intermittently, we gave it 60, slightly better. And then Montelukast given intermittently, similar. So what focuses for this is that intermittent therapy is certainly can be effective in younger children. Now, this is a 2001 MISS study, and this one's worth looking at again. It's a variation of the previous one, and it's more closer to what we practice. Now, initially you have two groups. You're randomized to two groups. The first one has daily budesonide, 0.5 milligrams at night, and at the time of colds goes up to twice a day. And then the intermittent high-dose budesonide during baseline therapy does nothing, just placebo, and thereafter a higher dose. Now, this is from the New England Journal of Medicine, and I apologize for the graphic, but I think the power of the graphic is that you look at it and say, this is the daily therapy in blue, and this is the intermittent. And even grossly looking from a distance, there's not much difference. Patients, patients without course of prednisone, see? And this one I always like is the best one. And you see there's no difference. And then over here, the frequency of exacerbations, of course, is slightly different, but not much. And again, over here, the frequency of treatment for respiratory tract infections, not much difference. So this, from the Ziegler study in the New England Journal of Medicine, we would conclude that intermittent therapy is effective. Now, the conclusions from us in pediatrics is the following. It is very hard to know when an acute event is happening. So it's hard to know when to start and finish the 7 days. We also know that kids in the wintertime can get up to 12 doses of uncortical steroids, 12 courses of respiratory tract infections. So it's almost as easy to give continuous therapy as to give intermittent therapy. I suspect it's easier to use intermittent, and I suspect when the kids are on chronic therapy that the compliance is poor and they really ultimately get intermittent. So we're close to this is becoming a standard for therapy, but not there. Now, I thought it would be good to explore from whence all these therapies came. If we refresh for a second, just thinking about, when I said I had milder asthma, we suggested that we could start with Montelukast and then progress to inhaled steroids. Now, this study was from Malmström in the Annals of Internal Medicine in 1999. The study was available prior to that. Now, really what I wanted to show you, and this study elegantly demonstrates it, that they treated patients, they had a control group, they treated them with Montelukast, and they treated them with inhaled steroid, namely beclometasone. And they look at FEV1. Now, I like FEV1 because it's the best, it really is the best flow PFT measurement that can be done reliably. Now, you can see from this simple and elegant diagram, they do better on beclometasone, but the Montelukast is half as good. Now, this is what we see in practice. This is what we see in practice. So, on the whole, we find that, but generally we tend to use Montelukast mainly because it's just easier to give. Now, in the early 90s, what we were figuring out, inhaled steroids were really becoming established as an important treatment for asthma. And this is a fluticasone study, delineated here by FP. Now, we knew that if you had inhaled steroids, and they were very, very effective. However, if a little was better, more was good. Now, we did know clinically that even giving more inhaled steroids, you did not get the bang for your buck. Now, this study by Wolf in '96 really established this. It said that if you give fluticasone at 88 mics BID, which is a standard dose, you got a good improvement in your FEV1. by doubling the doses and even quadrupling the doses, there was no effect. And yet, you were getting no major effect, but you were probably getting sort of side effects. Now, then this was the classical study in 2000, which really changed and brought combination therapies into vogue. There was a number, even at this time, there was a number of combination therapies. Now, this study looked at the combination of Ceravent and fluticasone. Now, it's an elegantly done study, and it just gives you some idea. Now, again, using FEV1. Now, if you follow along here, you see that, there was a slight improvement in baseline in the placebo. Now, if you look at salmeterol, which is a long-acting beta agonist also called LABA, you see there is an improvement with time. If you give inhaled steroids alone, clearly an improvement like we saw in the previous slide. But when you combine the two of them, there was ease augmented. Now, this heralded in the combination therapy. There was a number of combination therapies at the same time. You could combine inhaled steroids with montelukast. It was quite effective. And you could combine inhaled steroids with theophylline, and it had similar type results. These therapies seem to have won out, mainly because of easy compliance. Now, so the classical way of thinking is, if we have inhaled steroids, if the classical way of thinking of treatment on the use of control of medication is to go in this order, to give the milder medications first. And you usually start out with montelukast or low-dose inhaled steroid. If these don't work, you go to medium-dose inhaled steroids, and then you combine them with LABA, long-acting beta agonists. Now, the real issue is when you burn this out. If you give them the long-acting beta agonists and things are not working, and this is quite a significant group of patients, what do you do? Now, this is an important study that looks at this. And effectively what it just did, not to focus on it too much, what they did was they doubled up the inhaled steroids, or you combined it with salmeterol, or you combined it with fluticasone. I just want to talk about this in a second. This is an important study. Now let me just say it. And then they did lots of good outcomes. Now, what we see here, just to point out a few things, is the long-acting. This previously bore out the previous study. The PC20, the asthma control test, inhaled, NO, and then we will talk about this later. But generally, what happened was you did better on the long-acting beta agonists. Now, in this study, they noticed that certain genotypes were associated. Now, what this study brought out to us at that time was they did an important step forward here. They did they broke it out by ethnic groups. Now, the non-Hispanic, white, Caucasian did particularly well with the combination of long-acting beta agonists with inhaled steroids. You see in here. The combination of either a more inhaled steroid or a leukotriene receptor was not quite as effective. The Hispanic white population also saw a similar improvement with long-acting beta agonists. Now, what's intriguing was the difference, and this reflected the genotype findings. The African American population did better by elevating the dose of inhaled steroids. So overall, and this is important because there's some concerns about using long-acting beta agonists in the African American population. So this offers us a way out where instead of acting combinations of long-acting beta agonists, we can up the dose of inhaled steroids first. Now, usually what happens is when the combinations don't work, we add in Xolair, but there are other options, and I want to discuss another option, which is a therapy designed from the adult world, and it's from here in Boston. Now, to focus on this one a little more briefly. So, tiotropium bromide is a long-acting ipratropium. It is used quite commonly for COPD, not used particularly common in the pediatric or the asthma world. Now, the reason why this came up as an important study was not all asthma was seen as allergic, and we were seeing this more and more leukocyte-driven asthma, which behaves like bronchitis. And this group, led by Elliot Israel, wondered where tiotropium would be effective in this group. Now, they did a very similar study to the previous study. What they did was they had patients with they combined low-dose inhaled steroids with tiotropium. They doubled up the glucocorticoid, or they combined the low-dose inhaled steroids with salmeterol. And then they looked at the outcome. Now, what was really surprising here was the tiotropium combined with inhaled steroids was as effective as salmeterol. Now, why is this important to you and me? The reason why this is important to you and me is we're seeing more and more of the non-allergic asthmatics, and the combinations of inhaled steroids with salmeterol and combinations with tiotropium are attractive, and they're going to be explored more as our understanding of therapies for asthma develop. Now, what can we draw for conclusions here? Now, we're showing the treatment of asthma, the classical treatment of asthma still works. Follow the guidelines, and the guidelines are essentially albuterol as needed, leukotriene receptor inhibitors, or in low-dose inhaled steroids as first-line control of medications, and then gradually work up to medium-dose inhaled steroids, and then gradually work up to the combinations. Now, the second thing that we want to talk about is intermittent therapy. Now, intermittent therapy, I say here not proven, but it's close. For younger children, the data is probably there. However, it's not easy to give intermittent therapy. For one reason is you have to stop and start, and you never know when to start. So it is an option, and we are not quite there at giving it here in the United States. Now, long-acting beta agonists, I would encourage you to be selective. These are good control of medications when combined with inhaled steroids, should never be used alone. The long-acting beta agonists should be, now I mean not be selective, is they work particularly well in the Hispanic and Caucasian populations, but less well in the African American population. Now, and the third conclusion is use ipratropium or aspirin in more non-allergic asthma. Now, let's focus on a few questions, and these can serve as a little bit of revision to where we've been over the last hour. What best describes reactive airway disease? Now, this was the first slide I put up because this is particularly important for the pediatrician. Let's go through one answer to the question. It has allergic origin. It has a poor long-term outcome, induced by springtime allergens, not well controlled by inhaled steroids, or greater than 90% grow out of reactive airway disease by 6 years of age. Now, what we need to focus here is, let's go through each one. It has an allergic origin. It is not allergic in origin. It is related to airway size. Remember the first study from Tucson, the Martinez study. It has a poor outcome, quite contrary. The airways grow with time and you grow out of it. It is induced by springtime allergens. It is not. That's allergic asthma. It's induced by viral illnesses. It's well controlled by inhaled steroids, not particularly well controlled by inhaled steroids. They're certainly beneficial, but they're not. Now, this is the most important. Most people grow out of it by 6 years of age because of increased airway size. Now, let's put the question, let's do another question. Now, this one focuses slightly different. Now, I wanted to put this question up because inhaled steroids are core to our treatment of asthma. So let's just focus it. The use of higher dose inhaled steroids give a dose improvement in symptoms, A. B, is effective in combinations, and growth velocity alter growth velocity in the first year of life. Higher doses are most effective in African Americans with asthma. Compliance is poor. Now, the following is true except, it's a question. The use of higher dose gives a dose improvement. This is the exception. because remember we said increasing the dose of inhaled steroids does not improve your lung function and subsequently control. These are effective in combinations. Inhaled steroids are very effective in combinations. Now, we didn't talk about this. It does alter growth velocity, but the ultimate height is not altered by much. Higher dose is most effective in the African American population. This is certainly true. And compliance is poor, and we did not talk about this in terms. Compliance is about 30%.